My name's Tamara Credo. So a huge welcome to everyone. It's absolutely fantastic to see your faces and that you've made the time to come and join us for the SAGE panel discussion. Over the process of the SAGE project that some of you may know about, it's called the South African Guidelines Excellence Project, we've learned a lot about how challenging it is to develop guidelines from scratch, how long it takes and how expensive it is. And we've also learned that there are a number of people using alternative methods to develop guidelines for the South African context. And so we thought, having spoken to some of these people over the years, that we would bring them together to present their different approaches for us to all reflect on and learn about different ways to do it. So I will introduce them shortly, and yeah, it's just great to have you all here. And just to run through the plan for the program, so hopefully most of you would have received this. There'll be some extras for those that have just come in. The plan for the day is really to have as much discussion as possible. We have our panel speakers who I'll introduce shortly, and they're going to describe what they've done, what approaches they've taken for the guideline methods development, any challenges they experienced, and anything they've learned from that. And then we'll have a chance to check in with everyone and see if there are other experiences to share or questions for this experienced group. And then we're trying to pose the question, what should we be doing in South Africa when it comes to adapting guidelines or developing guidelines? And I've also asked the panel to each give a few minutes of a response on what their views are on how South Africa should be tackling this, and again, get your input on that. Moving on to the program. I'm absolutely delighted to have the lineup over here. You'll see there are more detailed bios in the program, and I hope you all have grabbed a program. On the table outside, there's also some other brochures or newsletters or other pieces about the organizations involved with SAGE. And on the back of the program, there's a little bit more information about the project. You can also find the full detail about the project on the MRC website, the Cochrane Center website. So I think what I'd like to do is introduce all of the panel speakers just very briefly in one go, and then I'll ask them to come one at a time up after each panel presentation. We can have one or two questions, but rather hold the questions over till all the panel people have spoken. So, firstly, I'm absolutely delighted to have Dr. Bev Draper here with us today. Bev is a family physician. She's worked in rural health. She's now working as in private practice as a kind of GP, but also specializing in mental health and counseling. But she also consults to the National Department of Health as a public health specialist, and in particular has been involved in an interesting guideline around health promotion that's fast coming our way. So it's great that Bev will share with us how they went about developing that guideline. Dawn on the end over there is a senior lecturer in physiotherapy at Stellenbosch University and has recently completed, congratulations, her PhD, graduated. And we'll be sharing some of her work on chronic musculoskeletal pain and how they've adapted guidelines for South Africa. Henk Temming, over there. We've got eyebrows, wave, okay. So we have, is a psychiatrist with additional training in public health, amongst other things, and works at Falkenberg, and co-heads the Division of Addiction Mental Health. But he has also tackled a very challenging process and developed the guidelines for management of severe mental disorders with comorbid substance misuse in South African psychiatric settings. And it's great that he'll be sharing with us their approach. And finally, we have Michael, who is a colleague on the SAGE project, is an emergency care practitioner. And if you read his little blurb, you'll see he's passionate about pre-hospital care, but he sounds like he's passionate about just about anything. He's also in addition, he's a clinical epidemiologist, but he's also involved in, he's a biostatistician consulting at the Biostats unit, and recently has been involved in a pre-hospital care national guideline, and will share how they went about adapting that for our setting. So I'm going to stop there, and I'm going to ask Bev if she wouldn't mind coming up and starting us off with the discussions.
Good morning, everybody. I stand here on behalf of my team, only one of which is in the room besides myself. So welcome, Nandi. But this is something I could possibly have not done on my own, and I'm really just presenting the work that we collectively put together, because it was a huge job, as you probably will notice. So we produced something called Health for All. The final title, and the one going around is still the sort of last to last draft, is Health for All, a health promotion tool for health professionals. And we were tasked to do this by the Department of Health. Why? Because they were looking at the burden of disease and saying that we're doing a lot of curative and we're not doing much preventive. The minister felt that we weren't addressing the chronic diseases, and so if you look at the chronic conditions that we experience as part of our burden of disease and the risks that we're experiencing in this country, there's a huge need for health promotion and for prevention of complications of chronic diseases. I've got a lot of information on slides. I'm going to nip through them so that we make time for questions. I don't go over my time. If you look at the health system and the delivery of healthcare, then health promotion and prevention really stands above everything else in what we should be doing in terms of first educating the population and preventing them getting to the point where we have to deal with so many chronic diseases. And HIV is a great example of that. So prevention is better than management. So it was quite a complicated process, and I've distilled it down into 3 points. The first one was to basically produce the guideline, and it's going around, you can have a look, and to produce this tool, which they had a vision for. And they wanted it to be a book or a flip chart on the desk of people giving primary health care. So the nurse or the doctor working in primary care, they wanted a tool to be on a one-on-one. That was our mandate. Secondly, we had to produce the evidence that underpinned this guideline so that we weren't just sucking it out of our thumbs, that we were actually doing an evidence-based guideline. And then we were also tasked with a training plan and an implementation plan of getting it into the system. If we'd known how much work this would all have been, we probably would have said no. So the process sort of looked like that. It was really the design, what was this going to look like, what were we going to put in it, where were we going to find the evidence for this, and then we realized that graphics was a huge component of it, and so it was quite important that we addressed it very proactively. And then training and implementation. The good news is that yesterday, Tuesday, was the last day for comment by the provinces. It has now been approved by the Ministerial Council and the Technical Council, and it is about to be rolled out. The funding is there, the funding for printing, and I'm hopeful that by July, August, we might see it to start pop up in primary healthcare facilities throughout the country. So that's really, really exciting. I think our basic, what it all came down to as we started to think and look at it was to say we need to shift from making a patient diagnosis to creating a patient profile. So we don't necessarily diagnose smoking or alcohol abuse. We don't necessarily diagnose somebody with risky behavior. But that is part of their profile, and the environment is part of their profile. And then secondly, we needed to shift clinical care to putting management back in the hands of the people that we serve, so that they would take responsibility for their own health, because we can't possibly look after everybody. Everybody has to look after their own health. So it is on you and me to go for a walk this evening, rather than somebody tell us to do it. And I just quoted that the field of health is changing from a disease model to a health model. So this was all about good health. So first of all, the design. What was this thing going to look like? They wanted it to stand on the desk. We had to go to the definitions. What is health promotion, health education? All of the things those terms that we toss around, we had to define that. The person was going to be the one in primary care, seeing the patient, and then what are the existing guidelines that are already out there? Because if you look at all the guidelines in South Africa, they've all got a little bit of health promotion in them, but there's nothing dedicated towards it. Secondly, the other things we had to look at was that we felt that pictures were going to be more powerful than text. So if we're talking to a patient, if you can show the visual, that they will remember that above just the words that you speak. They wanted a hard copy, and it's going out as a hard cardboard copy, and it's going to stand on the desk. And you're going to be able to flip it over to the page that's relevant. And it's going to be on the desk alongside the clinical primary healthcare guidelines. We decided to adopt a framework of to know and to do. I spoke to a lot of people in social marketing. You only remember 5 things. So from this morning, you'll go home and you will only remember 5 things, actually, unless you got the PowerPoints. And we thought, how do we actually make that work for us? So we said, what do people need to know and what do they need to do? They need to know 3 things. So if you're going out of here, remember 3 things, and what are 2 things that you can do about your health? And then it was all about communication for behavior change. Looking at what people do. Why do you go and buy a crusher at KFC? Because it looks nice. Is this what's in this for me? So it was all about that. Then we had to say that there are clinical guidelines out there, and this has got to take place within the consultation in the room. So how did we align health promotion into the clinical practice? If we tell nurses that they need to do health promotion before they see the patient, not going to happen. If you tell them to hitch it on to the end of a consultation, also probably not going to happen. So we had to integrate it into the actual process of consulting with the patient. And the clinical guidelines, which is known out in the Western Cape as PAC, I think, but is known nationally as Primary Care 101, uses an approach called, it says, assess, advise, and treat. So what we did is we took assess, advise, and treat, and we integrated this patient profile approach into that. And we designed an algorithm where you could assess the patient, and instead of just making a diagnosis, you would develop a patient profile, and then who would you advise? And we looked and said, who walks into our facilities? There are people who are really well. There's nothing wrong with them. There are people who have a risk, but they're not ill. So somebody comes in on a Monday morning with a cut on the head. They've probably been abusing alcohol, maybe, that's the reason, but they're not ill. They haven't got a condition. There's no diagnosis. So you stitch them up, but what about the risk? So they just have a risk, and then they have a condition. So are they at risk for a certain condition, or do they have a chronic illness? And so there were those categories of people. So who do you advise and how do you do it? And then you move on to treat. So the assessment and the advice was integrated into the existing clinical framework that is being used. And so we divided our contents into people who are healthy, people who are at risk, and people who actually have conditions. And then we had to identify which conditions we include in here. Now, pregnancy isn't necessarily a condition, but it isn't a disease, and neither is sexual health, but we felt we needed to put it in. And then we put in things like oral health, because we felt that that's really important for health promotion. So a lot of talking and a lot of backwards and forwardsing went into this. The process we followed was then we took all the advice messages in Primary Care 101. Then we looked at all the South African guidelines. For example, the TB page. We said, what does the South African TB guidelines say about health promotion? And then we added that in. We went to WHO, and they've got lots of health topics and interesting stuff, and we looked at those messages. We looked at the private sector. Discovery Health has wonderful stuff on the web if you're interested. So they have a whole lot of brochures on all kinds of chronic illnesses and risks. So we went there, all the NGOs and the private people. We went looking at integrated disease management, because how is this going to fit into the flow of the construction? And then we went to other countries and we said, what is there out in other countries in this format? Interestingly enough, there is no health promotion manual anywhere in the world, as far as I know, that covers everything. There might be something for TB or diabetes, but there's nothing comprehensive. Same as Primary Care 101. There's very little like it out there in the world. It's very unique. And we found particularly Canada and Australia, who have developed guidelines for Indigenous people, have had wonderful stuff. So we had a look at that. And out of that, we took all the health messages that were out there. And we said, these are the messages that are going out about health promotion. And then we followed a process of applying theory, of the general theory of health promotion. And somebody did a whole lot of research and distilled all that research and said, what can we apply to create a health behavior model that we can actually change behavior? Because that's what it's about, is actually changing people's behavior. And then we applied the evidence, and through that, a selection of selecting and refining and aligning those messages with our health system. So that's how we did it. Then we looked at the evidence and we said, how do we do that? So the next thing was the evidence. So we took the framework that we had and we looked at all the health messages. We ended up with 164 health messages out of all of that. And once we populated it and said, no, that needs to go in, because there's a lot of reiteration in various guidelines, what goes in? And then we applied the PICO approach, which was looking at each health message and using PICO to interrogate that message. And then on that, we did an evidence search. So we said, for each of those health messages, what was the evidence? So our approach was that we first went to WHO graded guidelines from 2010, and we used those, and if we found something there, we were very happy that that was good evidence and we didn't have to go any further. If we couldn't find that, we went to Cochrane, and if we couldn't find anything in Cochrane, we then went to systematic reviews. And Cochrane did some systematic searches for systematic reviews for us, and came up, I think we did 6, I don't know if Joy's in the room, but we did about 6 of those. And then if there was no evidence after that, we then either excluded the message, but there were messages we left in because they were no harm and we knew that. For example, screening for breast cancer, we know that's important, but there wasn't a lot of evidence. And in fact, the recommendation was mammography. Well, we know that in this country that's not going to fly. So we had to look at that, and we had to look at service messages as well. So some things are like, go for a pap smear is a service message. It's what the nurse delivers. You need to have a pap smear. And we kept those in. And at the same time, all the time, we aligned it with what the National Department was already saying. There wasn't much that was in conflict, but there were some things we had to figure out. We then came up with, eventually, an evidence document that had 164 messages in it, and each message under the topic is then interrogated and referenced, and that's just an example of saying under hypertension, use less salt. There's evidence from WHO. We also found stuff in Cochrane, and then that is what is in the yellow, is what comes out from National Department. Similarly, getting physical activity for high blood pressure, we got good evidence in WHO. We needed to go no further, but we also, in the final document, added what the guidelines say in the National Department. It was really important to know that the graphics were there, and the graphics were what we're going to engage. And I just made a few slides just to show you how important it was that doing health promotion, we went on the principle that these pictures created a narrative where people could identify themselves, whether they were standing on the side or whether they were actually participating or just watching, that we had this wonderful artist, and she did all these pictures, which you will see as this thing goes around. And we just used that narrative as the to know. Do you see yourself in there? And if you do, what do you want to change? And then we had, from the to know, we went to the to do page, and the to do page on high blood pressure was, no, this was actually physical activity. Are you getting enough physical activity? And these are the things you could do. These are the things that you could actually start doing tomorrow that would make a difference to your health. So every single one of those conditions had a to know and then a to do. And we repeated the narrative in that page so that people could engage with it. Then the training. They wanted us to do it in 3 districts. So 1 minute. Okay, 2. So I'm not even going to go into this, just to say we did the training. I think what I wanted to do was just go over the challenges. So the challenges were to identify what guidelines were out there, that there were no other ones like it, so we had to do it from scratch. That the evidence process was huge. For me, as somebody who wasn't used to that, it was quite big. And the stakeholder input. So we had to meet with all the programs at National Department. They changed their minds. We had to have more meetings. It was that whole thing. The timelines, we were completely unrealistic. We probably needed double the time that we made for it. The training was very challenging, mainly because of staff shortages, people being available, but very worthwhile. And it actually all came together in the end. And George Draper on my team designed the training manual, and has also designed the training for master trainers. And he's going to be doing that in probably July, August. When this rolls out, they'll be training all the master trainers in the provinces. But those were some of the challenges. The lessons that we learned was that you need to allow time for consultation, and we probably did that in quite a hurry, but there was this time pressure on us, that if you're going to do guidelines, don't agree to do training as well. That was big. To have a clear line of communication with the National Department, somebody who will walk the corridors and get people pinned down to meetings and pinned down to program. And if you call a meeting, just to say you're calling the meeting now, and make sure that somebody follows that through. So that was important. To get good evidence people on your team. And Nandy's sitting here. I mean, she was amazing. I would never have been able to do it without Nandy. To get people who really, really know the evidence process and to advise you well. And then good graphics. So the graphics needed to be consistent and look great and be engaging for people. The lessons learned, and I'm just putting this in because this comes from our pilot, and I thought it would be useful, that what we got back, when we went back after 6 weeks, after implementing training, and we ran focus groups in the same district and asked how it had gone. They said, the staff said they loved the illustrations and they loved the simple wording of the guideline. They said it supported their cultural dynamic. They said it was user-friendly, and that these messages were so standard they didn't have to think about stuff anymore. They could just do it. They said that people want to be well. People do actually really want to be well because they need to work and they need to be well for their children. That it was very relevant to all the patients, and the patients felt important. Most importantly, nobody changed any graphics. They loved the pictures. But the complaint was there are too many guidelines out there, and that there's staff shortages, and we can't all just keep going for training on guidelines. But the big recommendation was that something is needed for community health workers, And so that's our next task. So you think after having a baby, you sort of need to know that you always say you never do it again, but then you go back and do it again. So I'm doing it again. So I'm doing one now for community health workers, and that's going to be even more pictorial and more people-friendly. So we distilled it down to those messages, the rule of 5. Everything was according to 5. It was live well, so being healthy, and then if you have a chronic illness, those are the strategies. And we kept it very simple, very easy to do. We always said the nurse can take 5, or the doctor, you got a hand wherever you go. And it was always the rule of 5, and that worked really well. So just to be very practical in what we did, and I put that in just to show you that it was lots of fun as well. Thank you.
I'm Henk Temming. I'm going to present what we did in our guideline, the national policy guidelines for the management of people with serious mental illness and co-occurring substance misuse, so dual diagnosis. So we developed this guideline together with the National Department of Health, and we had a very small guideline panel, only 4 people. And I'm going to talk sort of about the methods mainly, and then talk a bit about the challenges and the lessons that we've learned in this process in particular. So just the problem of dual diagnosis, really, what we're talking about here is that there's a very high prevalence of people with serious mental illness who also have a co-occurring substance use disorder. So you have comorbidity, and we call this dual diagnosis or double diagnosis. And the consequences thereof is a lot of worse clinical outcomes in general, more medication side effects, a lot of risk-taking behaviors, HIV risk-taking behaviors, involvement in criminal activities, forensic involvement. So the consequences of having a dual diagnosis as opposed to a single diagnosis is quite detrimental. So this guideline was commissioned in 2015, and really it was a very interesting process because it was first of all commissioned and then sort of said, no, well, we were almost on our way to start, or in fact we already started. Then it was sort of drawn back, and it was we were recommissioned, and so it was an interesting process initially. They initially gave us 4 months to, actually it was more like 3 months, to do a draft guideline, and then we had 3 stakeholder workshops in a 3-month period in Eastern Cape, Western Cape, and KZN, where we got feedback from stakeholders on the initial draft guideline. So the panel was myself, Dr. Mike West, who's subsequently gone into private practice, Dr. Lisa Dannett, who's now at Groote Schuur, and Prof. Dan Stein. The audience was really target audience was specifically people with working in mental health care settings. It wasn't aimed at the primary care practitioner. It was aimed at the practitioner as a mental health practitioner, or a psychiatrist or a psychiatric nurse, or medical doctors working in a psychiatric setting in particular. We had to really limit a lot of the stuff because the brief we got was very vague and very broad. So in order to protect ourselves, we had to really narrow things down quite considerably. That's why we just sort of focused on this population in particular. The objective of the guideline, and this was an important objective, I think, because we need to know, because often in clinical practice you would get families and patients asking you, can I go for rehabilitation for my drug addiction if somebody, for example, has bipolar disorder and a drug addiction. And it's not always, there's always this fantasy that there is a place where you can get fixed. For us, it therefore was important to ask the question, are there particular psychosocial and pharmacological therapies that are more effective for people with dual diagnosis? And of course, it's always a comparative question that we ask. So the PICO we used was, the population really was people with serious mental illness. We initially said that schizophrenia, bipolar disorder, and a substance use disorder, mostly cannabis use disorders, or any other substance use disorder. We looked at psychosocial treatments as well as pharmacological treatments, limiting all of that to specific pharmacological treatments, not looking at agents that is used only for the treatment for addiction, for example, because those don't really get used in the South African context. The comparators, it turned out, within the literature was treatment as usual and in normal care settings versus specific rehabilitation programs, and comparative medications as per the individual's studies that we found. The outcomes, we had nine different outcomes which we pre-specified before we did the guideline. But the main primary outcomes was if there was a treatment that has to be effective or is effective, it should reduce your substance use and it should improve your mental state. We also, so basically what we included in our guideline was existing clinical practice guidelines and as well as systematic reviews. That was the source of our guideline or the research we used. And we also stipulated prior to doing the guideline what our preferences and values were, and that really was that in light of low quality evidence, we would lean towards weaker recommendations due to the cost benefit trade-off. So we did initial scoping search of different websites of various psychiatric organizations and people involved in dual diagnosis treatment to look at their guidelines. And from that scoping search, I designed a replicable search which you can conduct in PubMed. We also looked at the Cochrane Library for systematic reviews in the Cochrane Library, and we limited that to the English language, but also only looked specifically at guidelines published after 2009. So it really was the last 5 years that we were looking at. And I then selected the articles based on our predefined inclusion and exclusion criteria, which we also had. So for systematic reviews, we then went further actually to select articles, and we selected systematic reviews after we had appraised these reviews using the AmStar tool, and we had then predefined cutoff scores on that we thought were evidence of good quality systematic reviews if you scored above 8 out of 11, which is really an arbitrary cutoff, but we had to sort of choose some sort of cutoff. For the Agree-To appraisal tool, we used that to look at existing clinical practice guidelines. And there it was probably even more arbitrary because we decided to use the global quality rating, looking at all the different domains of Agree-To, but then sort of specifically focusing on the global quality rating. And if that was more than 5 out of 7, we considered it as good to excellent quality evidence. And then only one panelist conducted these assessments, these Agree-To and AmStar assessments, and we only included articles that scored above the cutoff. So then how did we extract data and how did we report? So basically what we did, we used the grade method. In case where there were existing systematic reviews, so if there was a systematic review in existence, there were only 3 of them that were actually in existence. We used the grade approach to basically grade the quality of evidence, but we also used the clinical threshold method. So, for example, as systematic reviews may differ from clinical guidelines if you use the grade approach specifically, and we use the clinical effect size method. So we wanted the outcomes to have a reduction of at least 20%. And this had implications for actually regrading a lot of it because imprecision then has to be redone, and you can't just use what was in the existing systematic reviews. We then use the grade approach with the evidence to decision framework principles to look at making recommendations and grading them as either against or for an intervention, and either a weak or conditional or strong recommendations for an intervention. So if there wasn't any systematic reviews, and that was in case mostly that was the case, we really adapted what was in existing clinical guidelines, depending very much on stakeholder input and the panel's views on existing clinical guidelines. And we then actually reported that and qualified that as there was no evidence from a systematic review available, but we used the clinical practice guideline, and usually the clinical practice guidelines would include some sort of evidence from randomized trials. So in brief, we had 42 articles that were eligible after the selection process. Only 3 systematic reviews were rated as high quality. 7 practice guidelines were rated as high quality. And interestingly, and this is very much a generalization, but our main result was really that across many of these primary and secondary outcomes for most of the interventions, there was no significant benefit of any particular psychosocial treatment compared to the treatment as usual or standard care. And that was an interesting finding, really, because it is in fact important when you deal with patients and families to actually know that. So basically, just a brief summary is that we found also low quality evidence and very low quality evidence, and the strength of recommendations were mostly conditional or weak in favor of most of the psychosocial interventions. For pharmacological interventions, there's very little data, and we actually recommended that you use very much the same approach as we would use for somebody who does not have a dual diagnosis and there was a single diagnosis. Nevertheless, we felt that there was a lot of stigma against this group within the psychiatric settings, and that we need to take that into account. So with the evidence to decision framework, equity is one of the particular considerations that has to be taken into account. And that was heavily weighed in our guideline, that we wouldn't sort of recommend against things, but we would rather be inclusive of this population and recommend certain types of treatment. The challenges was really the short time to do the guideline. And it was just a strange thing because initially the process wasn't that clear to us. We were told we need to give a guideline within the next 3 months, and I was working like a madman to get this done. But then if I look backwards, we actually probably had 1.5 years to actually do the guideline, because the stakeholder workshops was sort of happened quite soon after the draft, and then there was a long time after that where we could have actually also worked on it quite a bit. So only one methodologist. That was tricky because I did all of the ratings, and the ratings were commented on by the stakeholders as well as the other panelists. But when we did our outcome selection with the 9 outcomes, we actually did vote on which outcomes were more important than other ones, and actually did change the initial outcome order of preference and the critical nature of which outcomes are critical and not critical. But that was a challenge, only one methodologist. The sequence of meetings was not always ideal, so we would have these stakeholder workshops and then inputs from the stakeholders, and then we had to redraft things. It would have been actually easier if we had the stakeholder workshops first and then sort of went back and actually looked at the guideline in a different way. That was sort of also a problem. There was also a scope creep. So people at the stakeholder meetings would say, actually we want to include sort of child and adolescents. We want to include forensic populations, which we didn't include. We want to include maternal health, women's health. So everything had to be included, and we just simply did not have the resources to actually include everything. So we had to actually fight the various sort of suggestions that were made that needed to be included. The cutoffs we used for good quality was actually quite arbitrary. That was also a challenge. The grade was, the effect size method we used for clinical thresholds was tricky, because if you have a continuous outcome in grade, you have to actually look at the original power of that study. You have to actually look at it. It's much more tricky than a relative measure of association in that you have to recalculate things. It's quite time consuming. We had quite a bit of PICOs. In fact, we had nine outcomes, and there were about, I think, 10 comparisons. So it's quite a bit. It's more than 50 different PICO outcomes. So it was quite a lot, actually. Luckily, we only had 3 systematic reviews, so it didn't have, we couldn't grade everything. So weak evidence, we had to change that to conditional because people were feeling that weak doesn't, so just sort of says, you shouldn't be using it. That had to be changed to conditional upon resources, usually that is the case. Difficulty with understanding sort of the confidence in effect, sort of the notion of grades, quality ratings. It was really difficult for people to actually follow. And also you had to kind of always stress that the guideline was comparing was a comparative nature of randomized trials or even systematic reviews, and that seems to have sort of, you had to really reinforce it, that we're comparing things against each other, and that's what we're sort of saying when we make a recommendation. So we also eventually probably, the current guideline hasn't been changed yet, but we have decided that we should really be changing. We can't be saying that we make no recommendation of one particular medication over another, because that's problematic. You have to sort of say, well, you can use this, but the evidence probably isn't that great that it works better than something else. But it was quite tricky, actually, particularly with the pharmacological, because essentially we felt we had the initial grade sort of papers. If you read it, they do state that you have the right to sort of make no recommendation in light of poor evidence, but that's subsequently changed. So the search was also interesting because I conducted it in February 2015, and now 2 years later, when we had to redo a lot of the stuff actually because it's old. So I've redone a search end of last year, and we came up with quite a number of articles. So that has to be sort of done really. Better planning prior to starting. I think designated roles is important. We were commissioned. Also clarity about remuneration. Most of the money obviously went to our department, but I don't really want more money. I just want more time. If you have 4 hours extra a day, that'd be great. So a larger panel across the national. It would be actually really nice that if we had more people from other centres in the country being part of the panel, not just part of the stakeholders. So there were stakeholders, but actually it would be actually nice to have a lot more people on the panel, a much larger panel. More than one methodologist is needed. I think a longer time frame. Also, clarity about what people want from us. That wasn't always that clear. What is the end product that they want from us? Plan the publication at outset. That's also, I think, important. I think that's it. Thanks.
Okay, good morning everybody, and I'll be presenting to you what I did as part of my PhD and focused on contextualization of a clinical practice guideline, and specifically then for chronic musculoskeletal pain. So I had a lot of sponsors, I just have to thank them, as well as my supervisors. So you might ask, why did I choose this topic? And looking at chronic musculoskeletal pain as a physiotherapist, that's one of the or in musculoskeletal therapy, this is one of the main conditions that we see. But further to that, a recent global burden of disease study rated musculoskeletal conditions as the top contributor to years lived with disability. So low back pain is number one on the list. Chronic musculoskeletal pain is really a global healthcare concern, but also it's a major cause of disability and morbidity in South Africa and the rest, sub-Saharan Africa as well. So it influences the patient on multiple levels, so it's a multidimensional phenomenon. And currently it seems like we do have some challenges in treating chronic musculoskeletal pain. And therefore we thought that how can we translate the evidence that's available and out there, how can we translate it into clinical practice? And clinical practice guidelines then is said to have the ability or the potential to enhance the quality of care, so enhancing patient outcomes, but also health systems outcomes in terms of cost effectiveness of care. So we thought, okay, a clinical guideline, that would be a good idea to summarize all the evidence-based options that is out there available and proven for chronic musculoskeletal pain. That was our starting point. So now to decide, if we're going to develop a guideline, what can we choose? Because there's so many options available. There's the de novo method of development, starting from new. We can adopt an existing guideline or adapt an existing guideline. We can contextualize existing guidelines, and most recently, Schoenemann has come up with a new term, developed a new word as well, adopt guidelines, existing guidelines. So the idea of adolopment is basically a combination between adoption, adaptation, and de novo. So that came out very recently. While I was busy contextualizing, they were busy adoloping. So it's a very interesting and very nice article to read. So which one to choose? What did we choose? We chose contextualization of the guideline, and contextualization has been tested in the Philippines. And that's the approach that we chose, going from the premise that we can't adopt guidelines from one context to the other when the context, the culture, the organizational aspects are so different. So we chose to, and we can chat about this a bit later, how do you make the choice which one you should use? So we chose contextualization, and basically contextualization is about using existing and high quality guidelines, extract recommendations from them, synthesize those recommendations, use them to create a new guideline but when you do it, you always consider contextual information with it. And so that, to me, as a PhD student, that sounded, well, this is something that I can do, but it was quite a big project, so quite a challenge. But we developed a conceptual framework for the study, and we built it on what the people in the Philippines did. I've just listed for you the 4 parts of the framework there. So number 1 is we did a contextual analysis. Then, needing the evidence, we did evidence sourcing and synthesis. We used all that information and integrated it, and then we also tested the guideline in an external review. So I'll go step by step through each of them. So the contextual analysis was really needed because we needed to know what are the contextual challenges out there if we're going to implement the guideline. We also wanted to know what the context is all about. So we included patients and healthcare providers in the study, and it was a qualitative study whereby we basically asked them about their expectations and perceptions about chronic musculoskeletal pain and its management. So this was a very strategic move because we wanted healthcare providers to participate, because if they participate in the guideline development, then hopefully when the guideline is implemented, they will develop a sense of ownership and it will ease the implementation of the guideline. And we included the patients also strategically because one of the critiques against guideline development is that there's no patient input or very little patient input. So patient perspectives was then also, and expectations was then also considered when developing the guideline. So in the end, after this qualitative study, we developed a contextual framework, and I've just given you some highlights about some of the main themes that came out of this study, the qualitative study. What influenced chronic musculoskeletal pain? There's a variety of contextual factors, and one of them is patient-specific. So things like patient educational level, what influences their adherence, how is their ability to cope with the condition, and how do they understand the condition. The management strategies that was offered to patients or that patients received, and what was really a strong finding there is the whole aspect of adherence. Do they adhere to medication? Do they adhere to the exercise that was prescribed, and also the factors that influence that adherence? Healthcare system factors were also very strong, and here was the availability of a multidisciplinary team, because chronic pain is so a multidimensional phenomenon. One would expect that the treatment of it would also be multidisciplinary. But access to rehabilitation practitioners and to psychologists was limited. And then the patient's own socioeconomic and occupational factors played an important role. The choice between pain and work. When I work, I have pain. When I don't work, I don't have pain. And that influenced then their financial situation. So these were all the contextual factors that we needed to consider when developing the guideline. Part two was the evidence base, because we needed to base our decisions or our recommendations on evidence out there. So we conducted a systematic review, much in the same way as Hank and his team did, systematic review of clinical guidelines, and we also used the AGREE tool to rate the quality. We found 12 guidelines about chronic musculoskeletal pain management, and 6 of them were of high quality. But unfortunately, most of the guidelines focused on pharmacological management and specifically management with opioids. So that was once again telling us that chronic musculoskeletal pain is not really being seen as having to be treated within a multidisciplinary team. But with a combination of all the guidelines that we had, we could actually develop a multidisciplinary, a more holistic guidelines and list of recommendations in the guideline. So there are still some gaps, but at least we have the multidisciplinary guideline now. So one of the main findings of the systematic review then was that we should perhaps shift focus from treating the chronic musculoskeletal pain or developing guidelines for treatment with opioids towards more multidisciplinary guidelines. The next step was, after extracting all the recommendations from the high-quality clinical guidelines, we needed to synthesize those recommendations, and that is the evidence synthesis part. So we ended up with almost 200 recommendations, which was a lot, and too many to put in a guideline that would be workable. So we had to distill them, and luckily we could merge some of them, and others we had to decide not to use, and we went through a thorough process of doing that, and I'll tell you about that shortly as well. But basically, those treatments that were not available in the setting to be offered, those we actually eliminated. So we ended up with a list, or a core set of 43 recommendations. And each recommendation was then underpinned by an evidence rating. So this is just an example of how we merged the recommendations. So if you can look at this little green block here, we basically looked for, say for instance, we had 2 recommendations, one from the one guideline and number 2 from a different guideline. We looked at, are they saying the same thing? In other words, is there uniformity of thought? And in this case, for exercise, there were uniformity of thought between the 2 guidelines. We looked for the level of evidence, how consistent was the level of evidence, and if you look at the second column, you can see there was a variety of evidence for this recommendation, and we had to use like a specific writing guide to merge those levels of evidence into one statement. And then we also had to look at the volume of references and how current the references were. So these were what we considered when we synthesized the recommendations. And this was also quite a lengthy and intricate process, and that's one of the challenges of contextualization, is this merging process. Now, to combine the information from the contextual analysis and then the evidence synthesis, those 43 recommendations that we ended up with, we had to combine them, and we did that in phase 3, which we called the contextual integration phase. So in the contextual integration, I invited a group of multidisciplinary members, including doctors, nurses, physiotherapists, psychologists, a whole team of about 27 people to participate in a consensus study. So the consensus study was 2 Delphi rounds and interspaced with a panel meeting, a consensus meeting. So during the Delphi rounds, I presented the recommendations, the clinical recommendations to the team with a level of evidence and the final wording. And they then had to rate whether that recommendation is applicable and should be included for a clinical guideline in the South African context. So we went through those 2 Delphi rounds where the panel evaluated each recommendation and validated it or not validated it. And that was a formal consensus process. We interspaced it with a meeting to discuss any problems or any concerns, but during the meeting was also the place where we generated the contextual points that would accompany each recommendation. So that was also quite a lot of data to get through. So then in stage 4, we completed the process by doing an external review of the validated recommendations within the guideline. So in the external review, we also included a patient pathway that was also developed as part of the contextual integration phase. So it was an authentic pathway, or what we thought a real-life pathway that we constructed from the evidence that the patients and the healthcare providers had given us in stage 1. We invited various healthcare departments as well as professional bodies, and also used one healthcare center to give feedback on the guideline. So principally, the people participating in the external review, they largely agreed with the recommendations within the guideline, but they gave a lot of feedback on factors that would influence implementation of the guideline, and that would include things like human resources, communication systems, and healthcare system factors. So we really gained a lot of information in phase 1 and phase 4 about things that we would need to do to implement the guidelines successfully. And so this is then one of the end products, or one of how a recommendation would look in the final guideline document. So one would be the recommendation itself, so the careful wording thereof. So in this case, we recommend exercise and exercise therapies regardless of their form in the management of patients with chronic pain. So the wording is really important, because when a patient or a healthcare provider reads it, they would need to know what to do or what not to do. In this case, it says that, and you also spoke about physical activity. I'm glad we can join there, that the physical activity or exercise is really important, and the evidence base for it is accompanied. There is evidence. We use the FACES scale, which would make it easier. If you see a smiley face, you would know immediately you can do this. But if you would see a sad face, then you know that you shouldn't do that recommendation. And if we use the yellow face with just a stripe through the mouth, that means that you should really think about it and use your own clinical judgment. So this recommendation basically says that we can use exercise regardless of their form, whether it be Pilates, yoga, stabilization, stretching, strengthening. Exercise works good for management of chronic musculoskeletal pain. And the evidence base for exercise is the same as for opioids, with just much less negative factors associated with it. And then this little table here is all the context factors. So you can see it's quite a lot. We can make it a little bit less, but in the final guideline document, this will all be listed in there, because that really points to how we can implement this recommendation and what would be needed to implement it effectively. So that we can definitely use for our implementation plan. One of the critiques against contextualization, I don't know if you can see that there's something missing there. We have the recommendation, we have the level of evidence, but we don't have a strength of recommendation there. And so while it is a critique, the context points is actually a positive factor, because we can allow the context points to speak to the strength of the recommendation. But that might be one of the things that, in terms of contextualization, that we have to look at, is to include the strength of recommendation as well as the context points that influence the strength of the recommendation. So in the context point, there's practice methods, equipment, workforce training, timing, reassessment, outcome measures. Those are all things that could influence the strength of the recommendation. So in the end, we ended up with 38 approved recommendations that is included in the clinical guideline. I have to add that the clinical guideline, we developed it for public healthcare practice, because the contextual analysis was done in that setting. But if you look at the evidence and the recommendations, it can definitely be used in other settings as well. So lessons learned from a personal point of view, I really know now what it means to contextualize. I don't think I knew at the beginning of the process. It's really an intricate process of semantics, wording, how to use your words appropriately and how to write it, but more so also is how to integrate contextual information into the recommendation phrasing process. And although we say that we want to contextualize or adapt, because de novo takes a lot of skill and resources, I found that there is some level of resources and also skills needed when you contextualize or adapt a guideline. When we did the contextual analysis, we realized from the feedback that we got from the participants that there's really a need for just a summary of information, of evidence-based options. There's a need for guidance, because the practitioners are so busy and they could really use a guideline on the topic. And then I just have to also say that I did this as part of my PhD, so I was basically the primary investigator. But if we use contextualization, then the guideline panel should really be involved from the start. That's very important, because we involved the guideline panel more towards the contextualization phase. But that is just because it was a PhD project. For future directions, we got a lot of tips on what would be important for implementation, and you also shared very much about the pictures and what is the best ways for education and training towards implementation. There's a little bit of controversy surrounding implementation of guidelines, and I think South Africa is in a very good position to learn from previous implementation studies and actually to take what worked and what didn't work and to develop our own implementation strategy for South Africa. Thank you.
Okay. Right. So thanks, Tamara, and thank you for the rest of the panel members. I'm the last one speaking. Was this on purpose, Tamara?
Yeah.
I thought so. So welcome, everyone. My name is Michael, and I'm presenting on emergency care guidelines. In other words, paramedic guidelines for South Africa. And for those that are on Periscope that are streaming this live and want to know more about my beard and want to ask me questions about my beard, you're welcome to tweet me at Mike McCall3 and also at Centre for Evidence-Based Healthcare. I'd love to hear your thoughts about what I'm presenting and about the day. So, I was part of a guideline panel team that was commissioned by the Health Professional Council of South Africa to plug a giant gap that was existing in emergency care in South Africa. And they requested that we develop an emergency care clinical practice guideline. And emergency care is the target population, is the people that are in the ambulances, the paramedics and the response cars responding to any kind of acute emergency in the community. And so to develop guidelines and guidance for them, I think we need to just take a step back and understand what is currently the situation when it comes to emergency care in South Africa. So emergency care to date, and even today, paramedics work on a protocol that's almost a decade old. So they have a current protocol that was developed by a kind of a GOBSAT process, of good old boys sitting around a table back in 2006, and back then it was probably the best way you could do it, and what they produced was quite acceptable. But now we're in a new era of evidence-based medicine, and we need something more robust that isn't just a GOBSAT, but something that we can trust, something that's based on best available evidence that is still contextually relevant and effective. So the other challenge that we face in emergency care is that it's a rapidly expanding profession. The scope of practice for emergency care is ginormous, and our mandate was to address that giant void, in a sense, with guidance, appropriate guidance. That was a particular challenge that we had to face up, and the scope was then very important to delineate that. The other problem that we faced in developing guidance for emergency care is that there are 7 different kind of qualifications in pre-hospital care, from a 3-week semi-first aid course to a 4-year degree to someone who can have a PhD in emergency medicine. And so there's a variety of registrations, up to 7, and you need to address all of those different registrations. So the scope is a problem, outdated protocols is a problem, and we really need to revitalize the profession in a sense, because the current scope is really just a list of medicines that they can use with indications, very skills driven, with some algorithms on how you should probably do that. 10 years down the line, that's very outdated, and that's currently still what they're using. So we used existing guidelines to create emergency care guidelines for South Africa. And I'll go through a bit of the process of how we did this. So we're all quite familiar with de novo development, developing guidance from scratch, doing a systematic review, synthesizing primary evidence, and eventually taking that through a kind of guideline panel process and coming up with recommendations. You can imagine that if you want to do guideline development for this giant scope that is emergency care, which ranges from pediatrics to trauma to all medical emergencies to acute mountain rescue and motor vehicle accident extrication, the scope is ginormous. And doing de novo development you can't. So using existing guidance is the key. So we used a process of essentially de novo development, but instead of searching for primary level evidence through a systematic review process and synthesizing that, we did a similar process by just synthesizing clinical practice guidelines that addressed our specific research questions. So it starts off with a similar process. You have your aims and scope that's defined a priori, together with a set advisory board that in our case was a very large panel of specialists, paramedics, methodologists, epidemiologists, and a methods board. We developed priority areas and we generated specific PICO questions that we wanted to address within our scope. This was quite a process, but eventually we came up to it. We then did a comprehensive search similar to systematic review methods with critical appraisal using the AGREE2 tool of clinical practice guidelines. And Henk found, how many guidelines did you find, Henk? Like 7 of high quality. Dawn, 12. We found 276 guidelines that addressed the priority areas and questions that we needed. We screened 1,000 guidelines. So we found a lot. And that in itself was quite a problem. So we found a whole lot of guidelines. AGREE helped us to cut that out tremendously. But in the end, that really helped. So from the 276 guidelines, and we'll speak about how we navigated through that in itself, we extracted recommendations that answered our specific priority areas and PICO questions. We did this similar to what Dawn was explaining. We used an adapt, adopt, or contextualize process. And I'll go through that briefly. So adapting was taking that recommendation or guideline and saying, actually, it answers our priority area and clinical question perfectly. It moves from one target audience to ours seamlessly. In other words, it's contextually appropriate, it's up to date, it's relevant, and it speaks to our PICO question directly. And the methods is clear. And that's adopting. That's first prize. If we can adopt a guideline like the American Heart Association for CPR, which is exactly what we're doing today, then that's perfect. First prize. We've just dealt a giant blow to the paucity of evidence that currently exists when it comes to guidance and emergency care. The next step would be contextualization. And that's also similar to what Dawn was speaking about, is where we have a guideline that's still robust, it's still up to date, it's relevant to our question, but the context is not the same. There are contextual factors that need to be taken into account. So then we move that guideline, let's say, for example, from the UK to South Africa and added contextual points. We didn't change the recommendation. We didn't change the evidence base. That all stayed static. What changed is how one would implement it in this setting. So it's a bit like passport control. If you're going from Joburg to Cape Town, you don't need a passport. You just go from one point to another. You're the same person, you don't change. But if you're going from the UK or from Cape Town to UK, you kind of have to go through passport control, don't you? You get a stamp on your passport. And that's a similar process that we did. We didn't change who you were. We just added some baggage to you to say, well, if you want to come to the UK, you need to bring a rain jacket with, you need to get your passport stamped. All right? That was essentially contextualization. And that happened within the context of an advisory board and that type of process. The next was adapting. And that's changing the fundamental essence of the recommendation. It's either adding new evidence from a systematic review, because the recommendation wasn't up to date or relevant, or if in the light of no evidence, which was often the case, our guideline panel would revitalize or just adapt the recommendation to fit our context. And that's a bit of a mismatch between contextualization and adaptation. The essence, though, is that we change the recommendation, and thus the original level of evidence that it belonged to fell away, and it would be based on whatever we replaced it with, whether it be a systematic review level of evidence or expert opinion from a panel. We developed this guideline. We had almost over 1,000 different recommendations, moving from trauma to medical, emergencies to pediatrics to obs and gynae. It was really big, and it really addressed not just the clinical pharmacopoeia aspect, but also the clinical thinking of paramedics. We note that the timeline kind of moves to end document design and implementation and updates. The same with what Henk described is our stakeholders that we reported to were very vague in what they needed. And so we had to set the boundaries quite soon. And part of it was we're not going to move into implementation, monitoring, evaluation, or how we take a guideline and move it to clinical practice. In other words, an end user document design. That we stopped at. We just developed a guideline. Right. So what challenges did we face? We faced many. Applicability of evidence was a big one. Evidence synthesis and quality. I'll go through them briefly. Applicability was that there were really few pre-hospital clinical practice guidelines applicable to Africa. So, and I think this image just explains it. This is the guidelines we found. Most of the emergency care guidelines were in Canada and US, Europe, Australia, and New Zealand. Less than 1% of them. 2 guidelines were applicable to low to mid-income countries in South Africa, or low to mid-income countries in general, when they come to relevance and so forth. Only 2. That's a massive problem. So applicability of evidence. So that's where contextualization is really important. If you're taking evidence from one point to another, you're going to have to contextualize. Evidence synthesis is a problem. That's what Dawn touched on, is we had almost 276 different guidelines. Every single guideline used a different way of classifying its level of evidence. Some used grade, some used some other tool, and so forth. Putting those together in one guideline was really difficult. So you could either merge them, which we found to be very problematic. So what we rather did is we describe a plain language summary of that original level of evidence recommendation. For example, if it was level 1A evidence, it would be evidence from a systematic review of randomized controlled trials. So we'd report a plain language summary of that level of evidence recommendation, which makes it transferable across recommendations. So evidence synthesis was a big challenge and a stumbling block that we had to get over. And then quality. With using Agree to in duplicate and independently grade all these guidelines, we found that there's a massive variation in guideline quality. And that's something similar that SAGE found out in its work. What we did find, though, is that international bodies, guideline clearinghouses, or guidelines endorsed by guideline clearinghouses, and guideline development groups like NICE and so forth, have great guidelines that we trusted and could use. But smaller projects and smaller societies, like individual counties in America, guidelines were very poor. Learning points? Well, we had 276 guidelines. Retrospectively, reflectively, I think it's important, if you are going to have such a large scope, to boil it down to a set key guidelines, maybe 10 or 5 key guidelines that answer the majority of your questions. And the rest you can make a decision around whether you have the time and the money to carry on. The other thing is evidence mapping, and we had a particular problem, 276 guidelines, many thousands of recommendations that address different things. We had an entire evidence map that we had to create electronically using a mind map tool to map our guidelines linked to questions, linked within priority areas, to see where the gaps are and so forth. So that was really important for us, to map your evidence and see where you're at. Searching for CPGs was a particular challenge also. You don't find it in PubMed and Cochrane. You find it in Google, and you find it in clearinghouses and TRIP. You find it in databases like NICE. So searching definitely for CPGs is different to searching for primary level evidence. Your CPG advisory board needs to have broad representation. But that in itself is a limitation, in my opinion, because having a lot of specialists on your board just tends to make it very difficult to deal with them. But essentially, the broader representation, and the easier it is with regards to transparency, which is the next point. If your board is broad, and you have a transparent process within that, and then within your target audience, the emergency care practitioners, our sense, that helps to build trust within the guideline process, and that stems to what Dawn was saying about getting everyone involved in this process. And that's really essential, which leads you to knowledge translation. We only developed the guideline, and a massive problem that we faced was, well, if you've got this great guideline, the National, the Health Professional Council is busy implementing it, but there is a poor transition from the guideline to how we're going to put it into clinical practice. And this is something that we should have addressed in the beginning or started planning for. And so knowledge translation, using CPG as a vehicle for change, as a mini policy, and delineating what that means and how you're going to do that from the beginning is essential and a definite learning point for us. So in the end, I want to thank my team, and this are the core panelists, Prof. Lee Wallace, Ben Duval, Peter Hodgkinson, Jennifer Pagoga, and Prof. Taryn Young. And together, we all come from various areas, but Lee Wallace is from the African Federation of Emergency Medicine, who led the project, together with the Center for Evidence-Based Healthcare and the Cape Peninsula University of Technology and Emergency Care, the Emergency Medical Care Department there. We want to say thank you. Currently, the guideline has finished its public review cycle. I think, Bev, you guys have finished yours now. You've finished yours now as well. We've also finished ours now. And is now going for the next step, which is how do we implement it. And we trust that this guideline will have impact in emergency care in South Africa and change the way we do clinical practice from a skills-driven space to a evidence-based medicine, critical thinking space. Thank you very much.
Sure, very different approaches, all aiming to do a similar thing, which was take guidelines and bring them to South African public. I'd like to open for questions for the panel, discussion points, comments. Yeah.
I want to say thank you very much to the panelists. This has been really enlightening for me. I have been involved in developing guidelines. I'm Liz Gwither from the Hospice Palliative Care Association and from the University of Cape Town. And with the Hospice Palliative Care Association and Pain SA, we've developed guidelines for palliative care, and we developed the clinical guidelines for cancer pain relief, which is a book rather than clinical guidelines. When you say take the 5 key points, it's really important. The exciting news for us is that the National Health Council have just approved a policy for palliative care for the country. And so the guidelines are due to be updated. And when I think about the processes that you've covered, I can see the kind of gaps and the mistakes, and also in actually doing it, how it should be improved. So that's one of the next steps for the National Steering Committee for Palliative Care, the guidelines and the SOPs. But my question comes to, what about the children? Because that's always been our issue, and especially in palliative care, a lot of the prescriptions, the medications, not so much the psychosocial and the kind of the rehab practitioners who are involved in palliative care, especially for chronic illness for children, but a lot of the medications are used off license because there's not trials done and there's no evidence. So you were talking about children in palliative and in emergency medicine. What evidence do you find for children, and how do we help when we're developing guidelines for children's care?
So thank you for that question. I think I'll try and answer that one for now. It was slightly directed to me. So pediatrics was a specific topic within the emergency care guideline that we dealt with, and we actually had a separate pediatric guideline panel that helped us with that, because we actually had to make a decision in the beginning whether we're going to deal with pediatrics at all. Because adult emergencies in itself is big enough. But the need from the board was, we need something, because at the moment there's nothing. And the evidence was lacking. There was very little evidence in emergency care around pediatric acute care. And so it very well dealt with setting our key priorities and then finding what there is and adapting it. Even if the evidence was extremely weak, we had to come to a point using the agreed-to tool and look at the recommendation and say, well, we can trust this or we can't. The assumption is that the evidence is static. So it was a difficult process, but it was together with a guideline panel, an advisory panel that assisted us in adapting a lot of those recommendations.
Can I just add that for us too, clearly the issue of leaving out pediatrics was, we simply couldn't put it in, but for my community health, the next step, we were doing it for community work, there's definitely a big pediatric component in that. And that's evidence for health promotion messages around growth, nutrition, ECD, all those things. We have to put it in. And then we're hoping that from that, we'll then revise what we have and then integrate a child program. For primary care, you cannot leave children out. They're an essential part. Yeah.
Thank you for that excellent presentations. I've got several questions, but I'll just stick with a few of them. So the first one that I have is, in terms of looking at these guidelines, the most important question is, who asked those questions? Who started off with asking about chronic backache or psychiatric? Which decides what is that question? How do we prioritize it? And I know resources are limited, we all know that. But there's a lot of people duplicating this work across the board. So the EDL process will look at guidelines, someone else will look at a guideline. And is there a mechanism by which, like you have for trials, research trials, that a website where we actually put down what the guidelines are being done? That's the first question. Based on that, do we have the right representations on these panels? Because as long as we know who's there, I did see someone said preferences and panel values, they do have impact on these diseases. So if I choose a panel that I want a certain viewpoint, especially where lots of children or psychiatry where there's no data, you get a panel evaluation of an opinion. So how do we choose these panels that decide what the recommendation is? Because that's crucial in terms of determining whether your recommendation is valid or whether it's actually acceptable. And then we all spoke about reasonable time, which is, what's reasonable time? These things are evolving processes. Today it's there, and you'll never be, as you correctly said, you did this over 3 months, but 1 year later, the data's changed. So we need to be forthright and say, this is the best at this point in time. And we're going to move on. And when it comes back and there's a need to relook at it, we look at it. I think that time will never be adequate because there's always a process involved in in how we do this. And then my most important question, and everybody says we are hamstrung with resources. And we all spoke about implementation. But the reason for actually doing a guideline is to change practice. And yet we're all not monitoring whether it works. So isn't that a big failure if we're actually just creating more and more guidelines, which everyone's doing that, because it's an easy thing to do, to write something down and send it around and get comments. But actually the point that really needs to be addressed is, does that guideline impact the end point? And I think it's fallacy to actually do these guidelines without actually seeing if they work. And I think implementation has to be part of the process. Otherwise, for me, we failed in the process.
Important also to look at, like you say, implementation to monitor the effectiveness of this guideline. And that must be actually part of the development of the guideline, the effectiveness monitoring of the guideline after implementation.
I don't know if anyone on the panel wants to.
I can maybe respond. Yeah. So I think I would agree that for me, certainly when we did our guideline, one of the issues is the representativeness of in the panel, the guideline panel. So I think, if I think back, I would definitely feel that if you do a guideline, you need a broader representation on the panel. For example, our guideline panel consisted of people within our division of addictions medicine at UCT. But it would have actually been quite good if we had people from other universities across the country, because that would be more representative. We were quite sort of clear, and if you look at most of the guideline, the ways to develop a guideline, we were quite sort of upfront about what our values were and preferences, and it's really about being transparent and saying what they are. They might differ from different sort of, if there were different people on the panel, but I think it's important to be at least transparent about what they are. So that will sort of obviously influence the way you look at the evidence. So transparency was important there. I think implementation is always, it's a different, it's almost a different science in its own, but that's also very, very, very important. I don't know if anybody else has maybe something to say on implementation. The interesting thing there is also within our guideline, we did consider, in fact, we never actually did that, but you should, in each guideline that you develop, you should have an auditing tool which then is built in the guideline so that you can then, so for example, if you have a particular service, you would audit your service against whether you fulfill the standards of that guideline. So I think it's important if you do set up a guideline, we never actually got to that, it was just sort of fell off the radar, but it's important to have an auditing tool where you can actually sort of audit whether your guideline is being implemented or not. Okay.
I think for implementation, we felt that having put it out there now, we're hoping it will create an appetite for research. So some of our key messages are behavior change and how we're going to measure that. We have a unique opportunity once it's implemented that somebody could go into various selected facilities and then measure, for example, our key message for TB is finish your treatment. So we could easily measure that. And it would be really great to go back and measure and say, well, how effective is it and how helpful is this, as opposed to places where it's not being implemented. So I think it does create an appetite for research, but there isn't funding in developing and implementing and then to research its effectiveness. So it has to be a separate process.
I just want to say that actually you are right. South Africa needs a central guideline body, and I think this is also where one of the other SAGE workshops ended, that we really need a body that governs the guidelines that are developed and that really ask the critical questions of which guidelines should we prioritize. And so we've taken the approach in terms of perhaps the quadruple burden of disease. Those should be prioritized, but I've taken a different approach in terms of saying, looking at years lived with disability. So we back it up with a global burden of disease studies, that these are the problems that's facing South Africa. But we really need that governing body to guide us and to also then assist with implementation. Then in terms of implementation, unfortunately, the literature, there's been many reviews, very recent reviews, that says that the guideline and its implementation doesn't have a huge success in terms of changing behavior change and changing the health system outcomes. And that's why I said that we in South Africa are actually in a good position to look at what worked in the past and what didn't work and develop something novel. Implementation science is a very new science, so it's busy developing. It's, I said, 10 years old now. So this is an opportunity for us, really.
Tommy Wilkinson from Price Assessor at Wits University. Thanks very much for all the presentations there. And I really appreciate the challenges as well that you all put up consistently through. And if I could distinguish between sort of the methodological challenges and the process sort of challenges, and it looks like you all managed and got over a lot of the methodological challenges that you had to either contextualize or adapt or everything else like that. But if we look at the procedural challenges, they seem to be one of the sticking points I'm talking about. Identifying the scope and the timing and the resources required, and managing your advisory boards, and even sort of interacting, say, with the Department of Health to ensure integration with existing processes and things. So my question is, on a scale of sort of 1 to 5, I guess, on 1 being not important and 5 being super duper important, how important do you think it would be for each of the panelists, for the guideline producing community of South Africa, to come together with some sort of standardized process guide for the processes for undertaking clinical guideline development?
On my side, from a scale of 1 to 5, and as a working in the biostats unit, I appreciate that. I would say 5. I mean, the getting consensus on methods and process, especially process, is essential to a successful guideline and transparent, robust, trustworthy end product. And delineating the processes between pre-guidance development, so what is the evidence base we're going to start off from, then the process of taking that evidence base, whatever it may be, and developing guidance around that, and then post-guideline development process, which is how do we take this product we've made, CPG, and implement it to have either policy level impact or at the bedside clinical impact. And so I would almost delineate or stratify your question into 3 processes: the pre, the within, and the post. And if we can get those things standardized, then we're A for a win.
Yeah, I think that's very important. I would sort of rate it as a 4, but I would also say that it's quite important that if you have sort of standardized ways of doing guidelines, that the people who commission guidelines, that they should also buy into that, and that there should be buy-in from them. Also, whatever organization is commissioning a guideline. So you don't, if you have a specific process that has to be standardized, then it needs to be buy-in.
My name is Ephraim. I'm from UCT. My question is directed to Dr. Draper, and a few things that were of concern to me that you brought out. Shifting your mindset from diagnosis-based to more of clinical profiling, and trying to take primary health care to the patient. I think there's a bit of mind shifts that are still happening within medicine, because I think we're still diagnosis-driven, and we feel that we're just one end of the patient. They're just giving the drug and something in that line. However, those two things I think are more adapted to in more of our setting where we have a huge patient load. And clinical profiling takes a bit of time, especially in an environment where we've been driven by diagnosis. So my thinking is that clinical profiling is that you try and adapt the health of the patient to their specific needs. I just wanted to understand, in terms of the guidelines that you developed, how did you account for the kind of workload that's happening in most of our clinics, where people are seeing over 100 patients in a clinic? I think it's a bit of a challenge, especially for me who participates in primary health care, to be able to account for something like that. Thank you.
I suppose that we are looking at the ideal situation. We're very aware of the constraints. I myself have worked in primary care, and I know that you're just trying to get through the day. What we're hoping is that gradually we'll move towards that. It takes a long time to turn a ship. And sometimes you do fly through patients, but we're hoping that slowly people will take on a more holistic view of their patients. I'm not saying that they're going to go through that algorithm in detail with every patient, but we're hoping that there'll be more of a sense of environment and the challenges people face and the risks that they carry, rather than just looking at a clinical diagnosis. So that is very ideal. Whether it will be implemented like that. In our training, we did case-based training so that after about the 5th or 6th case, people said it's starting to get easier. So it's something you take on, and it becomes a way of looking at a patient. And the comment was that in the beginning this is huge, but as you move along, it gets a little easier as you take on that methodology.
Thanks very much. So we need to move on, and then we can come back and if we have some time. But one of the questions I posed to the panel was, what should we be doing in South Africa when it comes to developing guidelines, particularly with the experience you've had with adapting guidelines or contextualizing guidelines? So I don't know, I can start with Dawn if that's okay. Unfortunately, time is not on our side, so you have to stick within the
Okay. I
few
think
minutes.
an important consideration would be fit for purpose. What is the guideline intended for? And then there's a couple of things that you need to think about. If you want to adopt, adapt, contextualize, or even develop, there needs to be an existing guideline. If there's not an existing high-quality guideline, you have nothing to build on, then de novo is what you should be doing then. Yeah. But in terms of contextualization, you need to consider the local context, the organizational factors, as well as human resource factors as well. But I think the most important for me is fit for purpose.
Yeah, I think there's many sort of points. I would say it's important that if you are commissioned or if you want to develop a guideline, before you start the guideline, have a few meetings with the panel before you actually go on to develop the guideline. Make sure that your panel meets regularly. Get an adequate time frame. Make it clear what the time frame is you're looking at. You're working. What is also make it clear what is expected of you. What the end product has to be, and what you're going to do with that end product in terms of publication. And also, I think you need to have more than one methodologist, I would think, ideally, on a guideline, so you can have a conversation if there's disagreements. I would also sort of say that you'd have to, I would certainly recommend that you use the evidence to decision framework when you come up with recommendations, if you're going to be using GRADE, because that's quite useful, looking at equity issues, affordability, feasibility, accessibility. Those issues are important. Okay.
Yeah, just to say I really like our colleague from WITS's idea that we standardize and we start saying, and I think we're doing that with SAGE, is that we're starting to look at a process that we're actually all following. What we found is that often in the absence of guidelines, people ad hoc develop their own little guidelines, and that's not helpful. So we need to standardize the process.
So I would agree. And I'm glad that the point of uniformity was brought up, and Bev, you're also speaking about it now. In a sense, for me, take a step back again. It's almost you need to change your worldview. So we all have our own worldviews. We have a theistic worldview or a relative moralism worldview, or whatever it may be. But in science, we also need to establish our worldview. So when it comes to developing guidance, in a sense, you need to set the foundation. And we need to decide, well, what is that foundation going to consist of? Is it going to consist of one stakeholder? Is it going to consist of all the stakeholders? Is it going to consist of National Department of Health with our patients or without them? So the foundation needs to be set, and those are the role players that will help drive this foundation. And in setting the foundation, in a sense, in our worldview, in a sense, we need to say, well, what are we going to be using as the baseline? So what are the rules of engagement, in a sense? Like what Dawn was saying, if there's no evidence, we're going to go down the path of de novo. Or if there is evidence, what is that baseline that we're going to consider as the standard? Systematic reviews, or existing clinical practice guidelines based on high-quality systematic reviews. And once we have that baseline, we can then start building our house. We can say, well, what are the pillars that we need in our house? We need economic analysis, so work that Priceless is doing, health technology assessments. But it's based on the foundation of high-quality systematic reviews, and it's transported in the vehicle of a clinical practice guideline. So equity, all those type of concepts. Knowledge translation is a big topic that came up now. How do we take this foundation and this house and make it a minivan that we can take somewhere, to wherever it needs to go? We need to move this house around. It can't just stay in one place. We need to, access needs to be addressed, and then quality. So what I'm saying, I think in summary, is foundation needs to be set. The kind of framework, the whole paradigm of how you do guidelines needs to be uniform, and that's really important. And then the value of cost effectiveness and those pillars in guidance development. But the foundation is essential. Yeah.
Thanks everyone. So some very, very concrete suggestions and learning points that we'll try and capture and also feed back to you all. But again, another opportunity to ask your questions or give some comments. Renier, did you want to say something?
So I want to start by saying I'm a pharmacist, and I'm really sad to see that Bev did not include pharmacists there. So the previous speaker was speaking about the long queues and waiting times at clinics and that they can't see them. But if I think about a patient, they have to every month go to the pharmacy to collect their medicines. And in health promotion and wellness, we know that you have to reinforce what you're telling the patient every time you see them. So for a patient on chronic medicines, they will only see their doctor twice a year, but they'll see the pharmacist 12 times that year.
To reassure you that in the Health Promotion Guide for Communities, we have a whole page dedicated to adherence, and very aware of the role there.
But we, at the school, we're doing a project where we're actually using our students in TB and cardiovascular screening because the nurses in the primary health care is just not able to do it because of time.
Yeah.
And what we've done is we've now actually done a follow-up project to see how many of those that they screen, the students, are actually positive. So I think we have a role to play.
I just also want to follow up, thank you for all of the comments, on that idea of having a guideline for guidelines, because you spoke about NICE, and NICE have a guideline for guidelines that I think it would be great to adapt and contextualize to the South African setting. But I also just want to thank you very much on your presentation. When I think about how important it is to develop that guideline for chronic pain, and we've talked about adapting guidelines from developed countries. America, the United States, and Canada need to adapt your guidelines for their chronic pain management, because at the moment they are having so many deaths from opioids for use in chronic pain that they are restricting the prescribing of opioids, and people with cancer pain are not getting the pain relief that they need because of those misprescribing, because they're not using those kind of guidelines. And I think we need to think beyond our adapting developed world guidelines to sending those out to the developed world for better practice worldwide.
Hi everyone. My name is Yasin. My background is really in technology and guidelines and guideline dissemination. And I have a question for the panel, but tomorrow perhaps directed to you as well, because I think we've engaged on this before. My question is, how well aligned are the efforts of SAGE, and particularly these efforts around, or other parallel efforts around contextualization, as mentioned by the panel, with the efforts of the Standard Treatment Guidelines, sort of Essential Medicines List Committee of the National Department of Health? And the reason I ask that is because I believe quite strongly that despite how well intended and how good efforts may be towards contextualization and the quality of the sort of local contextual guidelines that are developed, unless there's a real sort of central respected authority, promoting these things and actually enforcing the use and implementation of these guidelines, we know what actually happens on the ground. There's such sort of political fragmentation, whether it's between provinces, whether it's between institutions, and it's actually very difficult to sort of do that last mile, right? Actually have guidelines implemented. I know from working closely with the NDOH that it's quite a large and coordinated effort at the primary care hospital level, as well as pediatric guidelines that are continuously expanding with national representation from the entire country. And I know there has been some work before, between SAGE and the national department. But with respect to these points that were mentioned earlier about creating a central sort of guideline authority and creating standards, methodological standards for contextualization, surely these things should be very well aligned right on top, rather than taking place in a decentralized manner. And I'm asking sort of what kind of efforts and communication are happening at that level. I don't see it happening any other way, because otherwise you'll have sort of a separate sort of power base of guidelines. And I'm sure tomorrow, you've seen how coordinated the effort is on top. What kind of sort of activities are happening at that level?
Thanks, Yasin. So shall I? So thanks. I mean, so just for the broader context, SAGE is a collaborative project with the University of Stellenbosch, the MRC, and University of South Australia. And the remit of the project is capacity building and research. And we have to keep that in mind as we go forward. But obviously there's a lot of there's a lot of need, and there's been a lot of learning through the project, which is why we are evolving and we're entering into year 4, and we decided to focus now on issues around adaptation. And all of this then gets written up and shared as best as possible. And I think there are a lot of streams of work happening. So SAGE might be working on this component, Priceless and funding from and a project of priority setting and working with the groups at national and NHI, where we get to, some of the SAGE team can work with them on certain aspects related to clinical guidelines, which is just one part of the broader story of NHI. And other SAGE members are working with Department of Health in stroke guidelines, for example, and other pieces of work. And of course, we keep as closely as possible linked with the colleagues at the Essential Medicine List program, where they've been doing guidelines for 20 plus years, and they have as you say, they've got quite a rigorous process in place. They've got specific terms of reference, and I think this is all going to be. I think we're all going in that direction of being more harmonized. But we're trying to bring the threads together, and we're using our strengths in pulling together, for example, a panel discussion and building capacity, and linking with other groups, where we then can try and tie this all together. I don't know if our colleagues from Priceless wanted to add anything to that, but I'm sorry to put you on the spot. But just to say that there are discussions along those lines.
Yeah, no, thanks. Just to reiterate that it is critically important, yeah. And you're absolutely right, Tamara, with bringing the threads together, there's sort of lots of different initiatives there as well. And also just to note the importance of the National Department of Health and the Essential Drugs Program being the central player here. That we need to coordinate and make sure that those processes are absolutely respected and built in. So from the start of guidelines, to how they're implemented, making sure that they link up with those established processes, because you're right, they're the ones that's the thing that gets it implemented and matters on the ground.
Yeah.
Yeah, I think maybe sort of last point from my side, that it's
it's I'm sure these when we have chatted about this before tomorrow, I guess I just wanted to highlight that besides the procedural and methodological challenges, there are very real political challenges that actually form part of this whole process. And I guess this was the sort of end from the last summit.
Thanks. So and just to maybe, I think, the political challenges can also be seen as the political opportunities, because I think the transition to NHI is forcing us to think about how we speak across sectors and across groups. And I think that's something quite constructive and productive. So we're going to try and make the most of it. I want to take a last comment or two for the panel. Yeah.
So, I mean, a lot of what was said just now was one of the main points I wanted to make, because I think we need, besides having a set of rules for how to do this stuff, there's also needs a set of rules for the decision to do it. I mean, if government says, I've got a budget of 10 million or 10 trillion or whatever it is, there needs to be some set of rules by which that particular investment is spent. And I think that what I want to get at is basically that set of rules for developing guidelines has to be created to say this is affordable for this country, not just for medicines. Remember, education costs money, time, all of those are financial. So funding is an important thing, and if we don't have that, no matter how good your guideline is, you can forget about it. It's not going to it's not going to fly. So what we're trying to do it from the ground root level, but we don't know what the top wants, what the medical aids want. I mean, at the moment, even in Obamacare or any of our care at the moment in the medical aids, there is a limit to actually funding of everything. And I think we need those sets of rules to be put in for all players, not just government, but that then allows the people that are devising the guideline some set of rules to work with. Otherwise, some go with the pie in the sky. If they find a latest development in the Lancet, we want to include it. And others will say, you know what, I need to get primary care sorted out. And I'm looking for cost effectiveness of that particular intervention.
Thanks, Prakash. Yeah, and I think there are streams of work happening to understand what are the thresholds that define our, our benefit package. And then we've got so much expertise in the country on how we go about the methods of making sure we have rigorous, transparently developed products that then have to feed in with all those extra bits of information. So I'd like to just take a moment to wrap up the proceedings of the day and to say I'm just so delighted that we've had this range of disciplines come and speak to us. When I was listening, I was realizing we've got a paramedic, we've got physicians, we've got physios, and in the room we have a selection of people participating and interested in clinical care and clinical practice guidelines. We also see that at the moment, there's no black and white way of how we go about adapting guidelines, but we all recognize that if there is already a guideline, maybe we don't need to start from scratch. And if there are no guidelines out there, what are the different approaches that we can take to make a rigorous, transparent product? And we see that it's not straightforward, and predefining that and perhaps sharing the processes and methods that we've learned from these teams can mean that future people others doing it in the future could maybe build on these methods. This is something that isn't clear globally. This is not just a South African issue, and the reason Sage and the team wanted to bring this together is because I think there's a lot of learning here that we could share with others. And so I agree with one of the comments from Liz. There's no guideline on health promotion that brings together all the issues anywhere in the world. The same with PC 101, one of the primary care guidelines, and with the chronic musculoskeletal pain that integrates pharmacological and non-pharmacological approaches. So there's really a lot that we have to share, and I'm very grateful for the participation, the input of the fantastic panel and everyone who's come to join us today. So I'm going to say thank you, but before I say a full thank you, I want to remind you that we do want to take a photo, if you don't mind. We're going to quickly run outside, take a photo, and for those that can stay, there are a few snacks to be had and shared and more conversation. So thank you very, very much. Thanks.